I do continue to teach. Actually, I have a seminar in the periodontal department this evening, and I've had the opportunity to have an academic component to my professional career. From the minute I graduated from school, I've been on the faculty at Harvard, and I've also been able to do a lot of clinical research, some preclinical research. I was an editor of International Journal for 12 years. Before that, associate editor of 2 journals for 4 or 5 years before that. I've published more than 75 papers, and I continue to teach at Harvard up to this day, especially with the periodontal residents. So I'm there doing seminars on Monday nights, and then all the residents come and spend a full day in the office with me every year. So I think dental prevention and a strong professional and personal hygiene and maintenance program is critical to maintaining oral health. And it's a little bit of a lost art today. I think on the business model of dentistry, dental hygiene appointments have become very short and don't necessarily allow a comprehensive approach that we try to focus on. I think the first thing is giving these hygienists plenty of time with patients, and we have, as long as I've had the practice, we've had a commitment to having an hour scheduled for every patient for hygiene. With COVID and with the professional commitment of our hygienists, we actually have more than that scheduled today. So some of our hygienists are here for a 10-hour day with a relatively modest amount of time for lunch to see just 8 patients. So they really can give each patient not just the quality, but the time they need to educate them, to do the clinical work and full screening exam and x-rays and everything that's needed to make sure we're providing that care. As far as training goes, it's variable. It takes time. It takes time to build a working trust with a collaborative care model that we use with hygienists. And our youngest hygienist who leads the hygiene program is Evangelia. And Evangelia did an internship with me when she was in hygiene school, and then went and worked in some other offices for a couple of years before coming back and starting full-time with me. And I work very, very closely with the hygienist as far as how we work through training, and whether it's diagnostically, sitting and reviewing x-rays on patients, going over treatment plans. In her early years, I would sit and actually do some scaling on patients, scaling root planing on patients together with her in the room, so she could see how I might instrument some areas. She'll observe some of my cleaning techniques when I'm doing laser surgery to see how I'll use the ultrasonic device. So we've worked very closely in that development. And one of our other hygienists has been practicing over 40 years, and it's more an orientation as far as a collaborative approach to patient care than anything from a manual or simple diagnostic point of view. And our third hygienist, Patty, I met at a time when we didn't have any positions available, and I immediately created a position a day a month for her, which became 2 days a month. And at her peak, she was here 3 days a week. Right now, she practices 2 days a week, and she was too good to let go from the minute I met her. And so I've been fortunate we have such a strong hygiene team. The most important study club that I've been involved with is a component of 10 periodontists from around the country. And it's a Society for Contemporary and Progressive Periodontics. And for about 16, 17 years, we met anywhere from once to twice a year. And it let us, as we were developing in our practices, share clinical techniques, clinical challenges, practice challenges, observations about the changes in periodontics and dentistry and dental implants. And it's a very supportive group. These are close friends of mine that we can call on each other at any time and be there for each other to help support each other. There's not a playbook for how to run a periodontal practice in 2025 or 2010 as it was, or 2008 when we probably started working together. And having that group of leaders, a lot of these people are leaders in periodontics and implants around the country. Chris Richardson was just president of the American Academy of Periodontology in 2023, and it's a great group of people. Yeah, implants are very interesting because if you look at it from, I could show you 12 advertisements of pictures of implants. You might think they all look exactly the same. Could show you 12 implant kits. You may think they look exactly the same. And in my hands, if you took any instrument that I use and you handed me one that was almost the same, after about 6 seconds, I'm going to look at you and say, are you sure you gave me the right instrument? Did something change? And if you look in the details with implants, whether it's the instrumentation or the thread design or the screws, and you have to have trust in the manufacturing. There's a lot of different types of titanium that are used today. Fortunately, most of the titaniums are relatively safe from a biologic point of view with patients. Most of the alloys don't have much contaminants today, so we don't see allergic reactions to metals. It's not a concern, but the strength of the titanium can be a concern, especially when combined with certain implant designs. In addition to that, the thread designs have an effect on how the bone behaves. If we compress the bone too much when the implants are placed, we might get more bone loss or poor healing than expected, and we want implants that are going to go into the bone and lock in stable but not damage or compress the bone. So there's lots of details that become very important, and I can make most implants work successfully, but the details are important. I think if we have a endodontic infection or potential infection that can be managed well with endodontic treatment, that's the first criteria. If we have a crack on a tooth, that's not going to be solved with endodontic treatment if it goes into the root structure. If we have a crack in the coronal aspect of the tooth, we may decide that it's best to do a root canal if it's a very strong tooth, knowing that we've educated the patient that does not mean we can always save a tooth. If we have a tooth that has poor coronal tooth structure and there's not a anatomic obstacle, such as if there's only 5 or 6 millimeters to the nerve of the jaw, most other situations, we're going to be much better long-term with an implant than if we have no tooth structure at the top of the tooth to hold a crown. But we still value endodontic treatment. If we have a strong, relatively healthy tooth that has a limited root canal infection that's had previous root canal therapy, then we might do retreatment or even apical surgery. So we value root canal therapy, but we want to be diagnostically correct. We value root canal therapy, but we want to be diagnostically correct and not use it to get rid of a short-term infection if there's a crack in a root, if that's going to lead in very short time to having a problem that needs an extraction.